Hello, good evening, welcome. Thank you so much for joining us tonight and spending your evening with us. We've got a great session for you this evening, managing COVID-related mental health distress in general practice, a real important and topical session for this evening. So my name's Alison Burgess. I'm the manager of the Primary Healthcare Improvement Team here at the North Western Melbourne Primary Health Network. The role of our team is to not only support general practice in what you do, but also make sure we're providing some really good education and training events like we're doing this evening. Before we continue, I just want to make sure that we take a moment to acknowledge the traditional owners of the lands on which we're all meeting from today and pay our respects to their elders past, present and emerging. My job is to do the bit of the housekeeping, get all that stuff out of the way before we get into the really good content for tonight. So all of you joining and dialing in are muted automatically, so please keep your microphones on mute. But we do really want you to engage with us this evening. The sessions that we've been running more recently have been really well attended, and we've had lots of great discussion through the question and answer option. So you'll find that you've got a little a panel, and it's often sitting on the right hand side of your screen, but depends on how you're dialing in tonight. There is a question box in which we encourage you to type any of your questions at any point in time during the evening, and we'll stop at certain points to take those questions for you. There is also another chat box there. So that box is when you might be needing a bit of assistance, or you've got some questions around maybe the audio or the screen, and we've got Madeline, who's one of our program officers behind the scenes, who will be engaging with you if you've got any issues there. But if you have any specific questions for the presenters, please use the question box there. After the session, we will be sending you a follow-up email that will have some of the resources that are relevant to tonight's session. And of course, we'll absolutely have an evaluation form in there. And we highly encourage you to spend a few minutes to complete that for us. We really do take a look at what you've said and what kinds of education sessions you'd like provided for you going forward. So please expect that. We often have that in your inbox by the end of the session, or if not, first thing tomorrow morning. Just a couple more bits and pieces before we move on. I just wanted to mention a couple of other really relevant COVID-related sessions that we've got in the pipeline. We've actually got a session next week. So this is on COVID, the clinical care of COVID for primary care. So primary care and how you're managing it from a clinical perspective. We've got some case discussions coming through, some of the general practitioners that are doing a lot of work in this space, and a really good question and answer opportunity. And then on the 8th of October, we've actually got a session response to the shadow pandemic of family violence, the role of general practice. So we've got Professor Kelsey Hegarty from the University of Melbourne Safer Family Centre presenting on what's the current situation in family violence related to some of the isolation and that we're experiencing during the COVID time. So highly encourage you to register and attend those sessions as well. Okay, we've got a really full agenda tonight, some great speakers. We're going to start the evening with two shorter sections. Just bring those up there. So Jag Dhaliwal, he's an Executive Director of Service Development and Reform here at the PHN. He's going to begin just introducing us, a high-level introduction to the HeadtoHelp hubs that have opened up in our region very recently to give us a bit more of an understanding of that. We'll then move to Tom Keneally, who's from the HALT program, Hope Assistance and Local Tradies, so obviously mental health linking in tradies and blue-collar workers. So he'll give us a quick introduction to that and an understanding of how your GP clinics can become involved, or a GP-friendly clinic part of that program. And then the main part of this evening, we're going to move to Dr. Kaye Frankcom, who's a clinical and counselling psychologist, who will be talking about some of the mental health issues that you might be seeing in your practices during the times of COVID. And Dr. Dina Georgopoulos, who's a GP, doing a lot of work in the mental health space out there in our region, who's also going to bring some of her experiences of late, and we'll have some question and answer time at the end. So like I said, really great lineup, some really great presenters with some really good information, and that's all you need to hear from me at this point in time. So I might hand over to Jag initially. We'll get him to share his screen and his slides, and he can step on in. I think Jag might be on mute still, maybe.
Oh, there we go. So I was just saying thank you, Alison, and I was just checking in to make sure you can see my slides now on the screen.
Yes, we can. Yep.
Great. Okay. Well, look, good evening, everybody. We've got, as Alison said, we've got a busy agenda ahead of us. So I'm going to try and keep this short and to the point. with the purpose of really giving you a quick update on the new HeadtoHelp hubs, which have been established recently. Well, when I say recently, I mean last week. So very much, hot off the press in terms of this information here today. What are HeadtoHelp hubs? Well, the HeadtoHelp hubs are part of a pandemic mental health response. They are intended to offer a multidisciplinary, team-based approach, an integrated approach to supporting mental health services in community for consumers, but working with general practice. They will have on-site mental health support, as well as virtual support for those people that can't actually easily get to a hub. The team based at a hub will be a multidisciplinary mental health team, including psychologists, mental health nurses, social workers, and other workers. We see that as the hubs establish, they may have peer workers and other workforces within them as well, working closely with general practice, but also importantly through the hubs, developing a service response which is able to step up and step down care as a person's needs change. So really, really exciting new addition to the service mix across Victoria. There are actually 15 new mental health hubs, new HeadtoHelp hubs, which are operational now as of Monday last week, the 14th of September. Actually, these have been very rapidly established. Following a press release and announcement by the Prime Minister, I think on the 17th of August, that in recognition of the mental health impacts of COVID in Victoria, 15 new hubs would be established. So these have been established in 4 weeks, very much indicative of support and access needed now in community and not in 6 or 12 months' time. The need is very present now. What this is responding to is also recognition that presentation rates at emergency departments of people presenting in crisis, but also self-harming, particularly young people, are increasing rapidly. Specialist mental health services are also telling us they've had significant increase in call volumes to triage service. Many of those calls aren't necessarily suitable for triage, but are indicative of people that haven't needed to access mental health supports before now needing support, but not necessarily knowing how to navigate the mental health system. And of course, through our general practice colleagues and our psychological service providers, they're also telling us about increased demand they're experiencing, but also increasing difficulty in being able to connect people to services because the services are just so busy. So the hubs are intended to connect and integrate with the local service system to enable people to access the care they need in the right place and at the right time. The model that the hubs are built upon, which I'll come to shortly, is very much informed by consultation that we've been doing with primary care, specialist services, consumers and carers over recent times as part of our regional planning. So whilst these have had to be developed very, very rapidly, they are absolutely informed by insight that's been shared with us about what some of the needs are, but also what some of the key features of a good model need to look like. The way that the model has been designed is to ensure that it is scalable and can be replicated either within Victoria, within PHN regions, or indeed across the country into other states and territories, should that opportunity present. Whilst the hubs have been open for a week, we've taken a very gentle approach in terms of advertising. So you may have seen some, but the ramping up of advertising will happen over the next 4 weeks once the hubs are better established, workforces are fully in place and more conversant with the new service model. So what is the service model? So this is the model on a page, and what this is trying to describe is that there are 2 important and key features of the HeadtoHelp model. One is a standardized initial intake and assessment process, and the second is the actual hub and the hub team itself. But before we get into that, I just want to step back and just point out that What's been designed here is an open access model. So this is responding to the very significant need that people aren't knowing how to navigate the mental health service system. So really enabling people to self-refer or pick up the telephone and speak to an intake team and have a conversation about what their needs are, but also absolutely for general practice, emergency departments, other health services, carers, look, anybody essentially, to connect somebody into the service so that they can be supported to access the care they need. Primarily at the moment, it's happening by telephone. We envisage within the next 4 weeks or so, there should be an online referral form available as well. And ultimately, as the service is advertised and people know and understand where the hubs are, they'll be able to walk into a hub and access the same initial assessment to determine what support would best meet their needs. The intake and assessment process being a standardized process and using a common initial assessment and referral decision support tool is really key here, because the other thing that we recognize at the moment is the capacity in the system is really quite limited at the moment because there is so much need for support right now. So what we are trying to do through this initial assessment tool, which has been developed through the Commonwealth Government with an expert advisory group, it's actually intended to work with the consumer and through a multi-domainal assessment approach, determine what type and intensity of need a person may need at this point in time. So it's a more dynamic approach and one which looks at a range of considerations, including history, protective factors, risk, and other aspects to determine whether someone might indeed really be looking for a lower intensity support or might benefit from, say, a brief intervention or a virtual or telephone-based brief therapy approach, or whether indeed they have more moderate to severe, more complex mental health needs at this point in time, which might require a different type of service response. Our forecasting is also recognizing that we anticipate a lot of people that will be calling the service may actually just need some information and guidance to online resources, and therefore may not actually need face-to-face psychological therapies. So if we can support them to access the support they need earlier on, that should be of assistance to them, but also try and ensure that other services are available to those people who need them. Important to note also that the assessment process is graded on a 5-point approach, where it ranges from self-help through to level 5, which recognizes that some people might need more specialist and more acute care than can be provided in a primary health setting. And those people will be supported to access those specialist services through triage. And we are working with the specialist services to have an organised referral pathway between HeadtoHelp and triage. For those people that might have, might have a need, may need to see a psychologist or may need some clinical care coordination, again, through the assessment process, the intake team will work with that person to ascertain where and what type of service may meet their needs. So in essence, what I'm trying to say is not everybody ringing the 1-800 number will go through to the hub. They'll be matched to the right type of care, which may already be existing in community, and those people will be connected to that care. For those people that the hub is most appropriate, are likely to be those people that have a history of mental illness and more complex needs, perhaps needing some care coordination. And what happens when they're referred to the hub is that there will be a complete assessment there, treatment planning approach, including development of a collaborative shared care plan, likely with their general practitioner as well as other people involved in that care approach, including a feedback loop back to the GP or the referrer so that there's good coordination of the care that, that this person is receiving. I'll just go on to talk a little bit more about the intake and referral process, because that is new. That hasn't really been applied at this level or this scale in Victoria before. Our PHN colleagues in other jurisdictions have used this tool, and it is proven to be a valuable tool in supporting informed decisions about the most suitable and appropriate treatment choices, which could be a range of things, as I said before, from helpline to online virtual supports, through to psychological interventions, through to coordinated care, or indeed perhaps even recognising need for psychiatry involvement. Important to note that the intake will be undertaken by a clinical team. So whilst this tool will be used is to support a decision, it doesn't override clinical judgment that clinicians will apply in all cases. This slide here is giving an overview of the 5 levels of care that I pointed out in terms of the recommendations that might come from the initial assessment tool. And again, really highlighting that for those people that are allocated to a hub, they're likely to be in this moderate to high intensity type cohort. And they're likely to be people that have more severe presentations. They're likely to have a history of mental illness, but also additional coexisting conditions that need levels of care coordination and support. Again, I think this is a group of people that we hear from primary care colleagues that it can often be difficult to find an appropriate service type and support for these people. So the hub should provide an avenue to assist with that. So I mentioned at the beginning that there are 15 hubs across Victoria. Just as I'm talking to you, notice the slide still says proposed. Well, they are now all open. There are 3 hubs in each metropolitan PHN region and 2 hubs in each of the regional PHNs. In terms of our Northwest Melbourne region, we have hubs in Wyndham Vale, so operated by IPC Health on Ballon Road. We have an additional hub in the North Melbourne Hume corridor in Broadmeadows, operated by DPV Health at the GP Super Clinic there, and a 3rd hub which covers the central Melbourne area, operated by Clarity Healthcare, who are based in Brunswick East. So that's my rapid quick-fire overview of HeadtoHelp as a new addition to the service landscape in Victoria, primary health, mental health landscape in Victoria. Really, what I wanted to highlight today is that what it is bringing is a model which can work with community, general public, but also with general practitioners and other service referrers to help navigate the supports that might best suit an individual's needs and where they might be located in the region, but also to recognise that for many people, if they're not sure where to start and they do access this number, those people, if they're allocated to a hub or another service and they don't have a regular GP or haven't engaged with their GP, our intention is that that connection is made back so that there can be a good and well-coordinated approach to their care. Not sure how, I possibly may have got over time because I have a habit of doing that, but I might throw back to you, Alison, in terms of whether we have time for questions or whether we take those offline and come back to people.
Yeah, we might need to take them off.
Yeah, can I just
offline,
throw one thing I'll just flag to people is if there is a web page with some frequently asked questions that might be of assistance, so headtohelp.org.au, might be worth having a look at that.
Great. Yes, thank you so much for your time, Jag. We'll, like I said, we'll keep moving. And if anyone has any questions that they put in there, we'll pull them out and make sure they get answered post-session. And the follow-up email will include some more resources around, specifically around the hubs and how they're working. So certainly keep an eye out to that. So we will keep moving to make sure we stay on time for tonight. We've got Tom Keneally next, who's going to be talking us through the HALT program and how that links in with general practice and the opportunities for general practice to become involved. So we'll just get him up and running. Working behind the scenes there. Great. There he is.
Hey everybody, how you going? Okay, so can you see my slides there? No worries.
Yes, all good.
Fantastic. Well, g'day everybody. My name is Tom Keneally and I'm the Community Project Worker for Hope Assistance Local Tradies, HALT. We are a suicide prevention and mental health promotions charity that works primarily with tradies and blue collar workers. I'll just give you a bit of a background about us and the work that we do. Okay, so HALT was established in 2013 up in regional Victoria in Castlemaine after the suicide of a tradie mate up here. A very small community, a lot of tradies up here, and we'd lived and worked with Pete for a long time, and his passing left a community with just a plethora of questions. And no real answers. But one thing that was really apparent is that that community of tradies who had worked with Pete for years and were wondering whether was there anything they could have seen or noted, they realised we didn't have any language around it. We didn't have any language for what was happening for Pete. We didn't have any language around what was happening for our mates on the building site. As blokes, sometimes we really struggle talking about what's happening for us emotionally. And so HALT was formed to give tradies some tools so that they can have tough conversations with their mates, with their co-workers, and support their mates to go and access the helps that are available and not feel shame or guilt about the fact that they're struggling with their mental health. So we've spoken to over, we've spoken to over 100,000 tradies since we established, and one thing we wanted to do was create a network of GPs and psychologists that were really committed to men's mental health and that were happy to be centres for excellence for this kind of support for these tradies, these guys who very often have never engaged before, often feel a lot of mistrust and uncertainty about what's going to happen when they do engage. So to that end, we have established the HALT-friendly Clinic program in 2019 in Victoria. It's a really innovative and first of its kind type of program that works linking in the tradies and blue collar workers in specific communities with GPs and counsellors that live and work in the areas where these guys operate and that are committed to supporting men's mental health and suicide prevention. It aims to link our blue collar communities in with organisations that have a specific interest in suicide prevention and men's mental health. As you guys are very probably aware, men are more likely, are 3 times more likely to die by suicide than women in Australia. And unfortunately, especially in the tradie community, there is a real reticence to put your hand up for help. A lot of blokes seem to feel like they have to carry the whole weight and all of those balls that they're juggling in the air just themselves, so they feel like they'll be letting their partners down, their co-workers down, their boss or whoever down, their mates down, if they don't just carry on and push through. And obviously things can get very kind of pointy for us guys, and it can be quite serious before we finally put our hand up for help, or perhaps our mate spots that we're not doing so well and suggest we do access some service. So what we do is we give the guys tools to have a tough conversation with their mates. We let them know that it's fine to struggle and that there's no shame in it, and we contextualise that by telling our own stories of our own journey from sort of having challenges with our mental health to wellness again, and the fact that you know, we at any given time might experience difficulty, and that we need to pat our mates on the back when they do put their hand up for help. And we want to direct them to clinics in their area where they live and work, in their community, that know what kind of pressures they face and that have made a commitment to go, okay, we're going to make that experience for them, that first experience, a really positive one. So that's what the HALT-friendly Clinic program aims to do. very often, a lot of the guys who access the service after a HALT event may never have accessed a service before. I think that's a really important thing just to speak about briefly, is that so we try and make it as easy as possible for these guys to reach out. We've got companion cards that have tick boxes that go over some of the areas where they might be struggling, whether that's relationship issues, grief and loss, gambling, I'm drinking too much, you know, I just feel depressed all the time, I'm fighting with my partner a lot, where they can just tear that off and hand that to the GP at the HALT-friendly clinic, so that they can get that conversation started, perhaps without just having to sort of find the words for it right off the get-go. Why be a HALT-friendly clinic? So obviously I'm talking to you guys today with the view to growing the HALT-friendly clinic program, and we hope that a lot of the people watching tonight do recognise that their clinics might be a good fit. Obviously, by signing up to be a HALT-friendly clinic, you're demonstrating to your community that your practice is committed to preventing suicide and improving the mental health outcomes of men and the tradies and blue-collar workers in particular. You're showing tradies and blue-collar workers that you recognise that you know, it's okay. We all face issues at different times, and you're committed to providing that safe environment for them where they don't feel alienated to perhaps come and talk about things that they find really challenging, I think. And also it demonstrates to your community that you're committed to normalising this conversation around mental health. We talked to the guys about the fact that it might not be you today, but it could be you in a month or two. Just only a few things could go wrong, and suddenly we find ourselves in a place that we didn't think we were going to be. So we want to normalise those conversations and promote inclusion and understanding, so that you know, everybody feels more encouraged to seek help in this really difficult time. To be a HALT-friendly clinic, there's no fee involved. What we ask is that the clinics operate within that Northwest Primary Health Network catchment, that the clinic be prepared to have their practice staff briefed on the work that HALT does, and ensure that the practice has adequately trained staff in the area of men's mental health. Also be committed to professional development where necessary to upskill staff to maintain best practice. Agree to have a practice rep come out to our HALT events as well. That's a really important part of the HALT clinics program. So once a quarter, whatever fits with the number of clinics that are in the region, we ask that whether it be a practice manager, a psychologist, one of the GPs, that they come out to one of our events every now and then and just actually face-to-face give the guys the invitation to come and access service. HALT our grassroots, we're on the ground, we're with these guys talking. It has a huge impact to see somebody come out from a clinic and say, hey, this is who I am, this is the clinic I represent, and we'd love to see you guys. If any of you guys need support, please feel free to come and access our services. We also give all the attendees of our events a one-page flyer for all of the HALT-friendly clinics, so they can find the right fit for them. Just moving on. The other thing is that we want the clinics to be able to offer a comprehensive appointment for that first appointment. We talked to the guys about the imperative of getting that double appointment at the start, to be able to talk, to have some space and time to talk about what's going on for them, because it might take some teasing out between the patient and the GP to work out what's going on, and it may be the first time that that this bloke has put his hand up for support. So we let the guys know that they need to get that double appointment, and we ask that the clinics have capacity to offer that. Finally, we just ask that the clinics have our HALT-friendly sticker on the window, and our companion cards. We'll obviously provide you with those, and the sticker is very sort of unobtrusive. And the companion card just, again, has that tear off on the back, and then it has some key information regarding relationship counselling, alcohol and drug support, online services, specifically, you know, the HeadtoHelp hubs and stuff. That sort of thing will be updated within those cards in future. But just so that there's some available resources there on the counter as well. So to apply, there's an application form, which is at that address that you see there on the screen. Now, also, there's going to be an expression of interest form emailed out to all the clinics who are attending tonight. So we really encourage you guys to take a good look at that. And if you feel like your clinics would be a good fit for the HALT-friendly Clinics program, please get in touch, whether that's through the primary healthcare improvement team number, which is there on the screen, or you can contact HALT or me directly on the number that you see there. Thanks very much for your time, guys. We're really excited about working with more clinics in the region. And I think just to finish, we've just got a film that we'd like to show you all. Thanks a lot.
Thanks, Tom.
That one smile someone gives you will touch 10 people. Been involved in men's health groups on the peninsula for many years, and was quite interested in men's health, so I said, yeah, look, I'll come along. And I was quite impressed because at 7 in the morning to get 80 to 100 tradies together, granted there were free egg and bacon rolls and coffee, but you still get 80 to 100 tradies together in one place. You can spread the message.
Was very well received by our people. He's very clear, he's very relatable, he doesn't talk corporate speak, he just talks like he's having a conversation with somebody at the pub.
You could be sitting in the ute, driving somewhere. You could be fishing, camping, walking, watching the footy. I don't want you to wait till you get depressed. I want you to hit it in the arse early. Go and access some help. Talk to your mates.
But I think the real power in HALT is not actually the talk that they come out and do, it's the conversations that happen after they leave. They give out lots of information, they give out lots of contact details and lots of options for people to then go and seek support if they need it privately.
Males generally don't come into the doctor unless things have been very difficult or they get pushed in by their partners. And so when I see a male patient, we usually opportunistically ask them many things about their health, from mental health to sexual diseases to alcoholism to whatever might be appropriate.
We are a microcosm of society, so any kind of mental health issue that you come across, we certainly see it, and we're seeing more and more of it. My observation is mental health issues come in many forms and for many reasons, but they're coming thick and fast, and so people need basic tools for when it happens to them or someone they know or someone they work with or someone they love for how to access some basic support and some help to get people on the right path.
It's so rewarding to see people who get given the tools to change, to grab them and change, and you know it's not only going to benefit them, but their wives, their kids, their whatever relationships they've got, it's going to extend. And I'm privileged because I hear people's stories and I can hear the commonality between the stories. I can hear how they struggle, how they move through things, how they hit barriers. And I can use that knowledge to share with other men and to stop people from suffering, really, because that's what mental health is. It's a lot of suffering, and there are shortcuts that we can help people with.
Great, thanks so much again for your time tonight, Tom. And for those who are dialing in that think, you might want some information or maybe even consider applying for your practice, feel free to get in touch with Tom. We'll have all the information provided in the follow-up email as well, or you can just contact the PHN as well, because we've got all the details to connect you up with Tom and the HALT team. So thanks again, Tom. for your time this evening. We're going to move on next to some of the core part of this evening. Dr. Kaye Frankcom is up next. So we'll just get Kaye up and running. So Kaye is an endorsed clinical and counselling psychologist with over 30 years of experience. So super lucky to have her on tonight presenting for us. Kaye has held national roles in psychology, regulation and professional standards, and currently contributes to the mental health response in our region as a member of the PHN's Clinical Council and Mental Health Advisory Group. So really involved in what's happening in our region. So welcome, Kaye. Well, I think we're almost ready to go. I think Kaye might be on mute still. It looks like you're self-muted, Kaye. So if you're able to unmute yourself there on your device.
And there I am.
There we go. Perfect. Great.
All right. So hi, everybody. And thanks so much to the Primary Health Network for inviting myself and Dr. Georgopoulos along tonight, because I think we've been well briefed by these newish initiatives that involve primary health care with the speakers before myself. So I'm really delighted to be talking to you as a follow-on from that about helping patients with COVID-related anxiety and mental health distress. And I guess, like all of us here in Melbourne, you know, all of this started back in March 2020, didn't it? And I don't know about you, but back in those days, it was really the start of telehealth and the pandemic, of course. And I went along via, obviously, a webinar to a presentation that was getting given by some mental health clinicians to about 500 of us about what was going to happen potentially during the pandemic. And what's really interesting is to really look back on that. And what was said back then, that the realistic estimate for the pandemic was 12 to 18 months, which I guess is looking very much like it in terms of our move towards so-called our COVID normal situation. And that the only way it can end faster is with greater casualties, and social distancing is the only weapon we really have at the moment, that and masks. And it's probably going to be maybe a 5-year recovery for many sectors of the economy. But as essential services, primary healthcare providers, including GPs and psychologists and others, will continue to be working throughout that period, and that has also come to pass. So here we are now in September 2020, and we're in a stage 4 lockdown still, and there are border closures, and although they're starting to loosen up a bit, and some states are doing better than others, but still the pandemic is here. So just to introduce myself and why I'm here, I guess I offer to present this webinar topic because I felt for myself that there's been a level of despondency at the announcement of stage 4 that I really couldn't have predicted, both from my own patients, but also for myself. I found myself, and some of my patients have been the same, feeling anxious about the future, feeling the unpredictability and the isolation. So I wondered how to deal with it. I found other health professionals felt similarly, and as I said, so did my patients and their patients. So this was a really different state of affairs that none of us ever faced. So I started thinking about how to talk about this, and I have presented not dissimilarly on these topics to my own profession, psychologists and mental health clinicians, and also to other professions. So I hope this is of interest to you tonight, and I look forward to running through it with you, and then having Dina join us after I've completed my presentation. And we're going to have a bit of Q&A, hopefully. There's a questions box, which you're welcome to put in questions as we go along, and Madeline will stop me if there's some that need to be covered off during the presentation, or we can take them at the end as a panel with Dina and myself at the end of the whole evening. So I guess working through COVID-19 for all of us is, I guess we have to agree, has been a test of endurance. We've had the pandemic come on top of a summer of natural disasters, and I don't know about you, but there's a level of exhaustion that a lot of us feel from the ongoing pressure and the health anxiety, having to deal with that in our patients and in ourselves. And there hasn't been much of a chance for a holiday for most of us here in Victoria. And there's now a term for that. Did you know that? It's called COVID fatigue. So many people are working long days and looking at screens a lot, including particularly psychologists, but but probably also many GPs are doing the same and talking to patients on the phone. So one of the things that really struck me about this was that we have been deprived of the many supports as health professionals that would normally sustain us, and yet we're expected to provide the support services that sustain others. This is a big challenge. It's a challenge that's meeting us, I think, pretty squarely as we get to the end of what has been a very long year. So as we go through this presentation, I'll just ask you to think about your response to these questions. So what have been the perceptions that patients for yourselves have presented to you during COVID-19 and various stages of the lockdown? And I say that in terms of their usual health needs, how they describe what they are wanting from you, and how does that actually impact upon your relationship with them and your ability to help them? And what's the impact of telehealth been as the context of these interventions, whatever they may be in your context? So, and I guess what has been the effect of health anxiety on interaction with patients and on your therapeutic relationship with them and your own health? I think it can at times be pretty hard to hold the frame of our, what we usually think of as a consultation. When somebody says, oh, I've got to go and pick up somebody, and next minute they're taking you on their phone off to the car and you're sitting on their phone on video link in their lap while they're driving around the countryside. These things happen, and I'm sure many people have experienced them. And they really are a challenge to us in terms of who's in charge of the consultation, who's in charge of the frame in which we're used to working with our patients. A lot of people sort of ask the question about telehealth, and I guess I pose the question, have you had trouble convincing patients to try it? And what about yourself? Are you convinced or unconvinced? There's been a lot of research around that tells us that, generally speaking, telehealth has the same efficacy as face-to-face treatment, particularly in the mental health space. But there's a very new study, as you can see it written up there on the slide, that was looking at a group of participants in Canada who suffered from generalised anxiety disorder, and half were assigned to telehealth or telepsychotherapy, and half had conventional face-to-face therapy. And they were administered something called the Working Alliance Inventory, so they were looking at really the therapeutic relationship. And interestingly, they found that telehealth didn't really interfere with the establishment of that alliance between the patient and the therapist. Now, those of you who've treated people with generalised anxiety disorder will probably go, well, it's not surprising that anxious clients would prefer to avoid face-to-face. But interestingly, both groups actually went to a local clinic to undertake their treatment, whether it was to sit down in front of a screen and talk to a therapist remotely or do the face-to-face. So I guess the question is, if the other outcome was that participants showed a stronger working alliance in telehealth compared to conventional therapy, and were all more comfortable than the therapists were with telehealth, then where does that leave us? Where do we sort of now then sit, in terms of the idea of conventional interactions with patients, particularly with mental health difficulties? And if the generalised anxiety disorder patients who were doing telehealth had higher working alliance scores, were more engaged with the help they were getting, and felt it was less intrusive and less intimidating compared to conventional face-to-face, where do we go with that in the future? There are many colleagues of mine who have apprehensions about the efficacy of telehealth, although many of them have experienced clients enjoying and preferring it. And there are problems with technology, and there are problems with the difficulty of actually being able to eyeball a patient. Some of the non-verbal cues are quite hard to pick up on, and often, you know, we can struggle a bit with the fact that, as we've said before, we don't actually control the consultation in some respects. On the positive side, there's a lot less no-shows, and there's a flexibility for service delivery, which patients certainly enjoy. One of the things I think about telehealth, whether it's talking on the phone to a patient or talking to them face-to-face, but particularly on the phone, sorry, not face-to-face, via video conferencing, is to actually be listening for emotion. Now, this is talking about people who might have a mental health issue that they're trying to talk to you about, that you may already have knowledge of, or they are perhaps raising it for the first time. But I think as clinicians, we can emphasize explicit or implicit emotion, kind of to the distinction being that we would actually tend to respond to the explicit emotion, which might be expressed something like, I can see how angry you are. You might say that to the patient. But the implicit emotion is really what patients are often looking for, which might go something like, but even more so, I can see and hear your disappointment, and perhaps some rupture in the relationship with the primary healthcare provider. So with telehealth, I think often it's difficult to actually be able to listen for that implicit emotion that we get so much of from the non-verbal cues when we see someone, when they're walking towards us from the waiting room, when they're sitting in the room with us. So I think it's quite important to be able to bring both of those interactions with patients and to try and attune to their experience. And one way is to really be asking the patient, what is their preference in terms of the type of support and relationship they are seeking from you? And what are the things that they want to prioritise? So it means that we're talking to patients about their preferences, about whether they want to continue with the therapy they might have been doing with you, or the conversations and counselling they were having with you previously, or with another mental health professional that they're coming to talk to you about that counselling, and what sort of, and whether they have different priorities now that are a focus for them given COVID. And I think we need to check in very carefully as to find out whether their focus has changed. One way is paraphrasing, which of course is a very, in some ways, a standard and foundational aspect of listening and empathic communication. But we need to use that to really slow down, help us renegotiate the client's or patient's goals for the session we're having with them, whether you're a GP or a mental health clinician, and try and look for the kind of recurring themes that might be part of the experience that the patient is having, and work out how we might help them to intervene in those if they are not helpful. So getting a general sense of the person can be quite difficult, as I say, because we don't have that face-to-face element. So finding that some compassionate way to express our respect and care, and being careful in the way in which we speak to people, is going to be pretty important. So I like to talk also about the importance of how we structure an interaction with a patient. So being able to set an agenda for each session. Certainly my interactions with GPs as a patient at the moment in telehealth, I find that the agenda is more set around issues of consent and talking through the whole process of how that I'm consenting to doing the telehealth call, and not so much about the agenda setting. And I think it's important that we kind of talk with our patients about, in a transparent way, about what their needs are and how we can assist. So running through, sometimes for some patients it might be about they've got a list of issues that they want to talk about. For others, they want the catch up, or want to brief you with the things that have been bothering them since they last spoke to you. But some people also find that catching up process feels a bit annoying or irrelevant, or not important or significant to the context in which they're actually seeing you at the moment under the pandemic. So we need to think about what we need to know in order to help, and think about how we can be more relevant in our responses, and think about how perhaps health anxiety may be playing a role. So this is where I'm starting to bring in the idea of health anxiety. And I sometimes use a verbal K10, just go through the items on the K10 and just I read them out to the patient and just get a level of what's their emotional distress. You can also use an app called novopsych.com.au. As you can see, it's up there on the slide. And you could actually send the person the K10 to fill out digitally by you registering that person's name. And then the result of it can come back to you. You'll see the details of how to register with NovoPsych. There's a small fee involved, but it's a very helpful way to remotely get some kind of measure of people's distress levels when you can't give them something physically. So also checking in with a patient about halfway through a session or a consultation and asking, have we actually got through everything you wanted to get through? We're about halfway. What will be the best use of our time? And what would be most in line with what you wanted to discuss or wanted to cover? Or is there a pressing issue you want to talk about that you wouldn't want to get to the end of the consultation without addressing? These are sound quite kind of convoluted questions, but I think asking people what do they need that they would like to have addressed before the end of the consultation when we're not in the room with them is quite important to find out whether we've covered what they are looking for, particularly if they're not expressing a lot of emotion to us about health anxiety. So I think that one of the things to think about is also what has been our response as clinicians over the course of the pandemic. I think we'd be fooling ourselves to not say that there have been times where we felt that there's been a bit of an atmosphere of helplessness, of feelings that things are beyond our control, which often for health professionals is not usually where we like to be, and it's not usually our experience. And you might have had experiences where patients aren't contacting you because they're a bit intolerant of telehealth, or they feel that there's nothing really happening for them, so they don't really feel that they should be allowed to call you and talk to you about their situation or their difficulties. And somehow the technology makes them feel there's some change in their relationship with you. There could be an undermining of a sense that you have of being able to be an agent in the consultation. And I guess for some of us, it can feel like the authorities appear unreliable, and certainly your patients will report this to you. Because we've had varying advice about various services, not so much in primary healthcare, but in allied health particularly. There has been a lot of confusion about who can get help from what allied health services under what circumstances. So I think this has also left GPs in a difficult position. So there's often this sense that how do we do right for the patient, but maybe we can't because of the circumstances. So I would argue for clinicians, for general practitioners as well as allied health, there's been this sense of losing this control of the therapeutic frame, as I've called it. And maybe at times, we've had troubles with our own self-care. So I ask the question, how do you plan your work day, your leisure time for connecting with others when you're in stage 4 lockdown? Are you working in the same space? As you have dinner or talk to your family or friends or watch TV, you find yourself checking emails when you wouldn't normally. Do you suggest self-care activities to your patients but struggle to undertake them yourself? And what do you do when a patient wants to have a lot of contact with you? Or what if they're the reverse? They're not wanting to have any contact with you and tells you that they've got nothing to talk about. Some people are actually very happy with telehealth and with the circumstances of a pandemic, because they don't really actually like being outside and with people, and they feel like everybody's a bit more like them. So some patients want more of us and some want less. It's quite confusing. So I'm proposing the idea that health anxiety forms part of this new reality and part of the COVID normal, and will be part of it ongoingly. And it's really important that we all understand how it works and how to manage it. and we get ourselves up to speed with that. Because certainly when I trained, which was many years ago, you know, when we didn't really talk about health anxiety, we talked about hypochondriasis, and we talked about it as in a very punitive and judgmental way. And this is really unhelpful, and I think people still worry that they look like this, you know, a hypochondriac, which has got very negative connotations. So I think it's important for us to understand that there are a number of cognitive responses to COVID-19 that are related to health anxiety, ruminating, catastrophizing, other thought patterns. We need to think about what are some of the prevention strategies that we need to be encouraging our patients to undertake so that they can reduce their health anxiety, and to understand the role of reinforcement and avoidance in persistent anxiety symptoms. There's a need for problem solving, even when there's high emotional sort of investment, and conflict management for some patients as well. And it's very difficult really to do reality testing where there's a lot of doom and gloom around, and also where the advice seems to go from one extreme to the other, and there's a lot of it there. There's a lot to read about COVID, a lot of which is quite confusing to the general public. And of course, it's very easy to be self-soothing through overeating or substance or alcohol abuse, which again, we should be asking people about maybe as an indicator of health anxiety. So I guess when you think about health anxiety, basically the basics of it are, it's the fear of dying or ill health. It's obviously in high prevalence, and to some degree, like most anxiety, there is some reality to it. Of course, we are at risk in a pandemic, more so than usual for some of us. It's amplified through media. It overts our vulnerabilities for ourselves and for our patients. And I guess the interesting question, does it lead to a shared world and a shared perspective? So being able to talk with our patients about the experience of a pandemic, about health anxiety and their fears for the future, and that we're all really subject to the rules, and we all have fears and arousal levels that are triggered and need to be managed. And I guess realising that there's a reinforcing element of fear and avoidance when patients say to you they're feeling low and isolated. I guess the question is, sometimes I think it's good to say, me too. Me too, I felt that. I don't feel it all the time. I may not have health anxiety and distress like you do, but it's understandable to feel this. It's a very abnormal situation. So fears can be based on rational concerns in this sort of pandemic environment, and there is a focus on mortality concerns, and of course other concerns, financial concerns, concerns for friends and family, and so on. So I would say to you to think about anxiety in this very badly done flowchart that I managed to do. So sorry about the graphics, they're not wonderful, but I hope you can get the idea that it's a bit of a vicious circle. Fear is activated and enhanced by a lack of certainty or predictability, which we have at the moment. We react by avoiding the fear, we react by avoiding the fear, often by ruminating, catastrophizing, avoiding going out, avoiding doing a range of things that would be more helpful to do. And we have these protective behaviours related to that. So they can sort of look like obsessions and compulsions. And of course, some of them are being reinforced. You know, there is a mandate that we need to be wearing masks, which some people are quite compulsive about. And you can see all sorts of variations, as you know, of the way in which people are wearing masks. But this is not OCD, but it can look like it. And this difficulty with lack of certainty sometimes really is activated for some people. And it may be activated in people who've never had any mental health issues in the past. So I think the question is, what is a reasonable response to health anxiety in a pandemic? And how can we empower ourselves and disempower anxiety? How do we understand the way in which it works? So I guess the difficulty with inconsistency in guidance, the demand for certainty, these are all things I think we need to normalise for people. We need patients to realise that there is accurate advice, but sometimes it will be conflicting. And this global knowledge we have about COVID-19 will lead to competing viewpoints. So just this idea of healthcare and the environment, just being able to think about how health anxiety sits in the environment for ourselves and for our patients, that need for predictability and control, which we experience as well as them. Sometimes this has led to people not visiting their GPs for a mental health care plan, not getting routine checkups. Of course, this has been quite a bit about this in the news, which is good, but hopefully it will bring people to realise they need to look after their health. So there's an avoidance aspect. I don't want to know any of that news. I don't want to go out. I don't want to expose myself. So that constant, unprecedented level of system change is quite difficult for many people to cope with, and the change in service delivery, of course. So I guess I put it to you in terms of your interaction with clients. Do you just continue with the existing treatment plan you have with them, particularly people with mental health issues? Or do you sort of stop for a moment and ask what is the current context and talk about that and address it, just so that the patient needs to sort of think about the mental health and think about what sort of guide they need in these difficult and unpredictable times. As I've said to mental health clinicians that I've presented this to and to other doctors, we need to really put ourselves forward as guides in these circumstances, because if we're not the mental health guide for our patient, then who will be? It'll be the media, which won't be very helpful. So we need to be the voice of reason, the calm, being resilient, of how we are managing our health and well-being, even if we're feeling somewhat ill at ease and a bit rattled ourselves at times. So some of you would be aware of the notion of transference. It's just really the idea of the feelings and perceptions and reactions of patients to us and us to patients. It's common in all health interactions, and by and large, transference is usually positive. So we want our patients to be attached to us and to have a bond with us and to have an interaction with us that is positive. So I think one of the things about health anxiety and a pandemic is it's very challenging to actually realise that the transference could be different. In other words, the relationship stuff could be quite different between you and your patient, especially if you're trying to argue for some sort of rationality in the face of their health anxiety. And then they're saying, well, I've read all this stuff and, you know, the authorities appearing ineffective and there's all these announcements of various cures and all our freedoms are being destroyed. How do you actually react to this? How do we try and interact with people in a rational way? How do we not let our own health anxiety overwhelm us? And I guess how do we find our way forward to have that positive transference there and manage what can turn into negative transference due to health anxiety and mental health distress, certainly in our patients and sometimes in ourselves. One of the things I would say to you that is most obvious in this relationship issue between us and our patients is the transference themes that come, I think, out of the pandemic particularly, that are related to personality and strengths and vulnerabilities and the like, but really can be kind of grouped into three groups. Mood and attention related transferences or relationship difficulties. So the despondency, the despondent patient, the irritable patient, the distractible patient, motivational problems, people with anger, grief, loss, just very uncertain, or relationship related transference issues where the patient is very demanding and feels neglected or discounted, so which may be to do with past experiences, may want to avoid painful emotions, be inflexible, acts like a victim of the whole situation and has sort of lost their sense of agency in their own life. Behaviourally, you can see repeated patterns or actions that are maladaptive, excessive cleaning, watching government announcements all day, and so on. So sometimes these are really become ways that patients can attempt to avoid distress, anxiety and pain, but they're quite ineffective and unhelpful. And it's important that we find a way to be able to talk with our patients about how this pandemic is likely to create these kind of experiences. And yes, there is a threat to life and a threat to the health system and obviously to aged care as well. But it is quite overwhelming. But responding to it in these ways is often related to anxiety that is in turn related to an inability to really harness realistic thinking and to be able to work our way through what is in front of us. And of course, many people have a lot of grief over what should have been this year, and a lot of people are just wishing it was over. So I'd encourage you to think about delving into some of this with the patients who are not functioning very well, who are very distressed and are presenting regularly to discuss with you their problems, and to try and identify what is the function of that excessive despondency, that excessive lack of motivation. What is it that the patient is trying to communicate? And how can you share that with the patient without judgment? What are these repeated patterns of thinking or ways in which you hear them relating to the pandemic circumstances and health anxiety that you know are not helpful? What do you know about their past that you can help them to realise there's a connection here, and help them to see that we need to move past that, and that these are just things that have come from the past that are being triggered by the pandemic and by those earlier life experiences that are then mirrored in our current experiences. So I guess we're in this context where we don't want to let these transferential experiences run right for our patients or for ourselves. So self-care strategies, and as you can see, I haven't said there's self-care strategies for patients. I'm saying self-care strategies full stop. These are the ones we need to be taking care of so that we can take care of others. So we need to think about, well, what are the health promoting activities that help you to feel mindful, to think broadly about what you need to be doing in order to be more healthy? How do you manage, how do you change your experiences regularly when you're just confined to being, able to do things 5 kilometres from home? I mean, the parks are getting a big workout, aren't they? And what do you need to do to really galvanise a more resilient kind of more resilient approach, in the face of this adversity? And what resources do you need? Feeling better doesn't always mean you are better. You may need other things and help to become better at what you're doing to cope with health anxiety and the pandemic. So part of it is about helping people with problem solving and helping ourselves with it, of course, but mainly obviously talking about our patients, that it is about helping people to tolerate ambiguity rather than demanding that it be different. Why can't we open up? Why is our Premier holding us back, and so on? How do you reduce your rumination about these things? Thinking about, how they can be more realistic in their explanatory style, the way that they discriminate, these global statements they're perhaps hearing from others or thinking themselves. So I often say to my patients things like, when you're looking at the connection between self-care and problem solving, should we wait to feel better before we take action, or do we take action in order to feel better? So this is really inviting people to think at a slightly meta level, to getting embroiled in what they can and can't do. So it's a way of trying to change the conversation about personal agency and what can help and what doesn't help. And so I guess thinking about how we don't just pacify people and become, if you like, sort of part of what they experience is perhaps the social control circumstances that they feel they're in, but where we can actually help people to become motivated and to think about whether they can take action in order to feel better, rather than waiting to feel better before they take action, which may be a long time coming. So just casting our minds to the future, I guess I'd say to you, it's an interesting question to ask what will happen as we go back to work in our offices, and some of you have still been working in your offices all the way through. How will we prepare if we haven't been in the office? How will we prepare the balance of telehealth and face-to-face? Some of us may not want to go back and hope that we don't have to. Some of us have health conditions that make the face-to-face work risky. Do we wait for a vaccine? We've got a new telehealth end date, but will this be sufficient? These are interesting questions. And I guess I really encourage you to be talking with your peers about these things, about your anxieties, about, what your thoughts are, and instead of just listening to your own voice, as we often say to our patients, be able to speak about, your own thoughts and share those with colleagues who can help you to think through what is going to be your approach to both dealing with health anxiety and mental health distress in your patients, and also these big questions of what's going to happen down the track in terms of us returning to COVID normal, as it's going to probably be called, and how we distinguish what's possible, what's appropriate, and how do we kind of accept limitations when normally we tend to strive to transcend them, which is kind of, I guess, in some respects, anti our training and our purpose as being health professionals. The last couple of slides are just some examples of some patient resources from the Centre for Clinical Interventions. This one's on health anxiety. There's this one on breath retraining. They will be sent out to you as PDFs, and a few others as well, so don't worry about trying to read them. They're microscopic, unfortunately, on the slide. But you'll get to have those, and you're very welcome to distribute them as you wish. And you can also access the Centre for Clinical Interventions website. It's an evidence-based set of handouts that are suitable for patients. And just finally, I guess I'd say managing and transference in health anxiety, it's important to sit with the discomfort of the struggle. I guess accept our reactions without judgment, and also our patient's reaction. Have some compassion for ourselves and for them. And I guess know that some development will come out of this struggle, and accept that discomfort will perhaps lead to ongoing compassionate approaches to things that perhaps in the past we wouldn't have needed to deal with. And try and find a win-win. What can I do right now that will improve my situation or your situation if you're working with a patient? And just finally, I guess I'd like to also acknowledge that there are many of our colleagues who are in acute and primary care settings who are exposed every day to the potential of contracting the virus. And I certainly think of them and their struggles. And I thank you for listening to me this evening. And I'll now pass over to Madeline to bring Dina into our conversation. And there's my contact details, which you're very welcome to email me anytime.
Great, thank you so much, Kaye, for that presentation. And yeah, we will keep questions that might come through to the end, so we're just a little bit conscious of time. Want to make sure that we don't keep everybody too long tonight, but thank you so much. So we will get Dina ready to go. Yeah, we're on the right mode there, and we'll just make sure we can hear Dina. I think you might be self-muted, Dina, so if you can unmute yourself on your device.
I think I have done that now.
There we go, perfect.
Excellent, thank you, Madeline. Good evening, everybody. I'm aware that we've been sitting and doing a lot of listening, and I wanted to thank everybody that has spoken before me. I've been quite moved by some of the conversations, and also found myself getting caught up in thinking through some of the things that Kaye has been speaking about. I'm also aware, as the last person speaking, that concentration levels and attention spans are probably waning by now, and people are thinking about their dinner. And I'm conscious of not wanting to go over time. So my sense is that I will probably speak for a little bit less than what I had originally planned, just so that there is time for some questions. And I will endeavour to stay calm, even though I'm feeling really nervous on the inside. So here goes. Thank you again for this opportunity. I am a GP who has worked in a traditional family practice for many, many years, and always been interested in well-being and a holistic approach to care. And in the last 10 years or so, I have taken on quite an unusual job where I initially joined a public mental health service team to learn more about psychological interventions, and unusually for me, became quite assertive and ended up being fortunate in creating quite a unique position where I have stayed on in the public mental health service to try and build bridges between the specialist services and people working in primary care, both GPs and other mental health clinicians and generally healthcare providers. And the way I do that is by working with staff in the building and encouraging them to think of GPs as partners in care, and thinking also of the other mental health clinicians working in the community also as being partners in care. And that when we are sitting with people who are presenting to us at the mental health service with often the more severe end of mental health difficulties, or in our GP rooms where mental health work is a frequent presentation, thinking about working collaboratively with the person. So similarly to what Kaye was saying before, the checking in with people around how they're travelling, what they're looking for, what sort of help they're after is very important. Madeline, if we could move on to the second slide. I just wanted to take a minute to share with everyone a cartoon or narrative that many of you may have seen that I have found particularly helpful in one way. And if we just pause for a second to look at the narrative, it's a conversation between a worried human and a wise duck. The world is changing. It's always changing. Our lives are in danger. We're in lockdown. Life is always dangerous. We were never free. Many of us could die. We all get our turn. Nobody knows what's going to happen. Nobody ever knows. This makes life interesting. We don't know what to believe anymore. Keep an open mind. This also makes life interesting. We are living in strange times. When were we not living in strange times? You know, everybody's reaction to reading this narrative can be quite different, but the reason I put this up is that one of the things that helps me in remembering about the wise duck is that even though what we're going through at the moment is life-changing and we've not been through a pandemic before, it reminds us that uncertainty has always been around, and that in our communities a lot of people are facing fear, anxiety, insecurities, and don't know from one day to the next if their basic needs are going to be met, whether it be employment, housing, relationship issues, etc. And so the message that I take from looking at this narrative is, first of all, a reminder that the pandemic is a shared experience and that we're all kind of in lockdown and adapting our behaviour and dealing with our fears and adapting to change. But it also reminds me that what each of us is dealing with at a given point in time is variable, and that we need to take that into account when we are sitting in the room with somebody sitting across from us expressing distress. So if we could have the next slide, please, Madeline. Thank you. What this leads me to speak about is an attempt by me to try and represent some of the changes that I have been experiencing and some of the conversations that I've been having with colleagues at work, the people that I live with, and the patients that present to see us, around some things that we have in common. And the circles are sort of bubbles representing thoughts and experiences and feelings that are floating around and coming at me from every direction during the day as I'm walking around. And I wonder how many of you can also relate to some of the names that I've put to these experiences. One of the ones that I'm feeling quite acutely at the moment is brain ache, and by that I mean a sort of a tiredness from a busy brain, lots to think about, lots to reflect on, and a sense of energy levels waning or sort of reducing. A very familiar sensation of information overload, which has been recurring and persistent over the last 6 months, both at the beginning of the pandemic when there was a lot of information, a lot of uncertainty, and a lot of change asked of us. And then as the lockdown has continued and as it's become apparent that life as we know it has changed for at least this year, as far as I can see, the fatigue that comes with all the decision making and behaviours and routines that have changed, and the prompts that we need to remind ourselves around wearing a mask or remembering how to use telehealth, remembering all the different infection control measures, the challenges with personal protective equipment, the longer hours at work, the loss of familiar supports, a lot of the things that Kaye has already alluded to. And I think I'd also like to acknowledge that when I refer to these thoughts, feelings and experiences, I'm describing them and I'm coming from a place of being an educated person who is in work, who has supports in place, who is grateful for the security that I do have. But it also makes me appreciate if I'm feeling exhausted and achy and tired and overwhelmed and there's all this stuff going on, I'm feeling quite vulnerable. What must that be like for the members of our community who have been faced with job uncertainty, financial distress, relationship breakdown, social isolation through living alone? So hopefully in acknowledging that and thinking of those people, when I am in my workplace, I can sort of dig deep, if you like, and be aware that how people present and how they ask for help may be even more challenging than what it usually is. And given that demand for service that Jag described early on, that a lot of us would be very familiar with, the challenge for us is also about looking at what can we do and what can we focus on and how can we be of assistance and help to the people that we're seeing. Could I have the next slide, please, Madeline? Thank you. And so what I'm trying to capture when I look at these images are around this ride that we're on. I use the expression the Corona coaster quite often. My family is well and truly familiar with the ups and downs of the Corona coaster, And most of the time, I hope that I'm in one of the seats on the roller coaster and fairly securely strapped in, and I take that quite seriously, that responsibility to look after myself and acknowledge that if I'm going to be in a position to be there for other people in my work life, at home, I can only do that if I'm coming from a place of being reasonably rested, sleeping okay, trying to eat reasonably well, but also check in with myself and with others around how am I travelling, what do I need, how are the people around me going, what do they need, and learning to try and, well, some basic things. One of the things that I'll often say to myself, remember to breathe. It's not overrated. It helps a lot to just take a minute, take a second, slow down, pause, think about the personal resources that assist in coping, and that can be quite unique for people, and to be okay about that and do whatever it is that I need to recharge in order to be able to function better. The other comment that I wanted to make in hearing all of the presentations, and one of the sort of threads that we may lose sight of sometimes, is that one of the most valuable resources that we bring to our work is ourselves. And I will often be speaking with GP colleagues who ask about different psychological therapies, or a recommended clinician, or a recommended service or program, and getting it right for people. And I'd just like to remind us all that whether we are the GP, or whether we're a mental health clinician, a psychologist, a colleague, a friend, what we bring in into our interactions with people is a willingness to listen, a willingness to take time to allow a person to talk about how they're feeling or what they're thinking, and to try to be patient and not come up with a solution or a diagnosis or some advice or a quick referral. And that's challenging. I mean, time management is difficult in the general practice world, but I think it is helpful to be honest with people and say, there's a lot going on. I can see that it would be helpful, or do you think it would be helpful for us to make another time to talk some more about what might help, or how we can work together to get you some support. And it's really encouraging to see that the government has acknowledged that demand for services is so high at the moment that there are wait lists, and only people at the more severe end of distress are accessing us, public mental health services, and the EDs are busy. So I'm very pleased to hear about the HeadtoHelp hubs. And I've also just included in the last slide, Madeline, if you'd be kind enough to move to the next one, some additional services, or one of the things that I find more useful than anything else in all the resources out there are the one or two services or clinicians or more that I usually use. developing a relationship with those people and picking up the phone and asking them for some recommendations or some suggestions about a next step if the usual service that I use is not accepting new referrals. And people generally are very helpful and supportive in that way, in acknowledging that demand is higher than what actual availability is. Similarly to Kaye, I also use the Centre for Clinical Interventions website, and I really like the plain language resources that they have, both for patients, their families, as well as health professionals. I also wanted to mention a peer support group that my service has been running for quite a long time at Inner West. It used to be a face-to-face pre-COVID, but we now meet in a virtual meeting space, and the advantage of that is that we have capacity for new GPs to attend. And in these meetings, the focus is very practical, often based around a case discussion with my psychiatrist colleague attending as well. But what we try to do is create a safe space for GPs to learn from each other. And if anybody is interested to come along, you're very welcome to make contact via email. In the interests of time, I'm not going to go through the other points on the service and on the last slide, and I'm sure I've forgotten to say quite a few things that I had planned to say, but I'm going to pause there and open up for questions for Kaye and myself. Thank you so much for listening, and I look forward to taking any questions together with Kaye.
Thanks so much, Dina. We've so yes, just for those of you dialing in, obviously we're quite aware of the time, so if you can't stay for questions, no problem at all. But if you did want to quickly put any questions, we can probably field a couple. We've just had actually quite a few comments about how much people have enjoyed the different sections, so that's really great to hear. In terms of questions, is there a list of bulk billing counselling services that you're aware of? And that's maybe something we could help put together potentially as well. And it was sort of a question / comment on health anxiety is one part managed by counselling support, but economic anxiety is another part. And what can we do if that's the case, if there's no job or no income? And what if both family members have lost income apart from Centrelink? So a bit of a comment, bit of a thought, bit of a question all in one.
I think, Madeline, I would say, yeah, we've got the times ahead are not going to be any easier than the ones we've been through. And I'm sorry to say that, but it's basically the truth. And I think Dina is exhorting us to connect with each other because of this, and our patients are going to need us even more so, and they're not going to have money. And so all these questions about, you know, who's going to pay and bulk billing and so forth are really relevant. And I'm sure Jag has plenty to say, given the initiatives that have come from the federal government. These are going to be really important. It's going to be all hands on deck.
I mean, if I could jump in and add to that, Kaye, as well, just reminding people about the Care in Mind service through North West Melbourne PHN is targeted for people who might not be able to pay a gap fee or access a private service. So that is another option available to GPs.
Thanks, Jag, and we might be able to include that in the follow-up email as well, some links for some more information just to remind people of that service that's available as well. So we haven't had any more questions come through, just a few more comments from people. Just again, thanking you so much for your time. They've obviously really enjoyed the session and found it really helpful. It was good to have some good overviews of telehealth and agreeing about having the brain ache type feelings themselves. sure lots of experience in that sense. So I don't think there's going to be any last minute questions, but again, if people do have questions that come through, you're welcome to put them in the feedback in the surveys or respond to those emails, and we can try and follow them up for you. I'd imagine everyone's sort of ready to knock off for the evening, I think, and maybe go get some dinner. So thank you so much for Dina and Kaye, Jag and Tom for their time this evening. And thank you all for dialing in this evening. Obviously, as I said at the very beginning, we've got a couple more COVID-related sessions coming up. And we'll send you out the email with the evaluation and some of the resources that were suggested for tonight's session as well, just so we'll make sure you've got that there. So thanks again. Have a wonderful evening and hopefully have a great rest of the week. Thank you.
Thank you, everybody.